Welcome to Mamatoosa, Conversations with a Midwife. I'm your host, Atoosa Benji. A quick note before today's episode. This show talks about birth, life, death, and all the complexities in between. My goal is always to share stories that leave you feeling empowered, but please know that some topics may be challenging or deeply moving. Also, while I'm an experienced midwife, I'm not your midwife, and the information on this podcast is not intended to be medical advice. Please consult your healthcare provider when considering what is best for you as an individual. Now, without further ado, I hope you enjoy the show. Welcome back to the Mamatoosa podcast. My guest today is Dr. Sahar Wertheimer, and Dr. Wertheimer is a reproductive endocrinologist who is based out of here in Los Angeles.
Yeah.
I'm so excited about our interview today because I have about 4 million questions for you. Most of all, I love how I got to meet you because my dear friend Michelle Ray, who was on the podcast, she was actually, I think, my first or second guest ever.
Wow.
And she worked in a fertility clinic.
Yeah.
She still works in a fertility clinic. And I was telling her that I really wish I had a fertility doctor who could come and speak about and answer all of these questions that I have, because I have so many questions and so many theories and so many things that are going around in my head that I need facts about, that, and I'm sure my listeners do too, that I would love for you to be able to, shine some clarity on. And she was like, you know what? We had this awesome doctor who came in and she was going to work for the clinic and I think she would be great. And I was like, okay, what's her name? She was Dr. Wertheimer. So I copy and pasted it, put it into Google. You came up, I found your social media, and then I messaged you. And here we are. And it actually turns out that we're in the same community,
Yes.
essentially.
Yes.
So really welcome to the Mamatoosa podcast. I'm honored to have you. And tell me a little bit about who you are and what you do, and what is the difference between a reproductive endocrinologist and some of the other doctors that work in the field of obstetrics.
So I originally am from Florida, and that's how I ended up in LA. It kind of had to be similar weather, temperament, though it is better in LA. I did medical school, OBGYN residency in New York, and then I came here for fellowship. We loved LA and we're still here. I am a mom to 4 kids, have been through my own women's health journeys as well. That's part of the reason why I am so attached to this field. I think that, and I'm sure you can relate, we see women in their very vulnerable moments and we get to witness them through a lot of good and a lot of bad. And I think it's so special that we can connect on certain moments and offer empathy and hope in addition to maybe the medicine and the science. And so I am very passionate about helping women educate themselves and empower themselves. I've seen such a shift from, a few years ago, even when people are always coming, and I'm sure you experience this in the community, like, oh, hey, what do you think about this that my doctor said? Or what do you think about this? And I like to really encourage women to advocate for themselves and speak up. Why shouldn't you ask your doctor that question? Like, why are we so intimidated? And I think that, with social media, with podcasts like this, we're really providing a lot of context and education for women, and women are so motivated. So happy to be here.
It's so important, the work that you do. I'm interested in the work of reproductive endocrinologists. You have to be an OBGYN in order to go into the specialty of reproductive endocrinology, or can you be an endocrinologist who specializes in reproductive endocrinology?
Great question. So yeah, being a reproductive endocrinologist means that you are OBGYN trained.
Got it.
So you've done 4 years of medical school, 4 years of OBGYN residency, and then 3 years of fellowship. Other fellowships in the field include like urogynecology, GYN oncology, minimally invasive. And so all our fellowships, I think, are about 3 years. So it's been a lot of school. Endocrinologists do overlap with us a little bit, and a lot of times we will collaborate with medical endocrinologists, but they do not do IVF procedures just because I think we're more procedure trained and we're more women's health and pelvic anatomy trained.
Got it. So will you do, for example, if someone comes to you and they have a fibroid, would you be the one who removes the fibroid, or do you send them to a surgeon who would do that and then proceed with the infertility treatments after that?
I would say that for fibroid surgery, I don't do that anymore, or major fibroid surgery. I will do small fibroids that are inside the cavity hysteroscopically.
Right.
But for major fibroid surgery, I think these women are better served using a minimally invasive trained doctor. These are doctors that are doing, many cases a day, every day a week, and they're taking out massive fibroids through small incisions in the abdomen. And I find that my patients are better served that way than with me.
Could you explain the difference between a fibroid and a polyp?
Absolutely. So a fibroid is a smooth muscle tumor, a benign tumor of the myometrium or the muscle of the uterus. And it essentially is an encapsulated growth, and it can be anywhere from the outside of the uterus, the serosal side, to the endometrial side. They can be anywhere from a couple millimeters to like massive, and making women look pregnant, etc. They're benign. They usually cause heavy and painful periods and sometimes what we call bulk symptoms, which is when they press on surrounding organs in the pelvis and can actually in extreme cases cause damage to the kidneys or bladder, etc. Polyps are, the way I like to call them, overgrowths of the lining of the uterus. They're endometrial tissue. They typically have like a feeding vessel that allows the overgrowth, and they are not made of muscle tissue. Both can inhibit implantation, and whether or not to remove them becomes a question that we deal with in our field quite often.
And it's interesting because when I think of the uterus, which is this typically hollow organ, unless you're pregnant, to think of a fibroid growing on the outside was something new to me. It was actually, I learned about it when I started midwifery school.
Yeah.
Because I always thought of it growing inside the muscle and being fed by the vessels from the inside.
Right.
But it can actually grow on the outside.
Yeah.
Which is
You can have some really interestingly shaped uteri.
that too.
Yeah.
Which make for interesting births.
Yes.
Once they get to our side.
Absolutely. And fibroids could be a reason why fetuses don't necessarily turn to be head down.
Correct.
They can be very space occupying and very pesky.
They can cause issues for sure. As can women who are pregnant and have had some sort of fibroid removal surgery because the lining of the uterus now has scar tissue.
Yeah.
Can you talk a little bit about that?
Yeah, so this is where fibroid surgery becomes kind of more nuanced in discussing for somebody with infertility. So if it's what we call like a pedunculated subserosal fibroid, that's easy to remove.
That's a mouthful.
That's a fibroid on the total outside of the uterus, easy to remove, really won't affect much. But fibroids they have grades from type 0 to type 7, and they can be anywhere along the wall jutting into the cavity. And so sometimes when you want to remove a fibroid, you're actually going to need to dig into the muscle of the uterus, and that can do some damage in a couple different respects. One is it can weaken the muscle of the uterus. And so women who have had very extensive myometrial fibroids removed are sometimes recommended to get a C-section so they don't labor with the weakened muscle. The other thing it can do is, unfortunately, sometimes can cause scar tissue of the lining of the uterus because of all the healing that's involved. And that's why, again, I say that it's so important to go to somebody who's well trained in removing them minimally invasively. So a MIGS provider, because they can really minimize the scar tissue.
So a fibroid could you have a situation where, like, you would have placenta previa? Could you have a fibroid that blocks the exit of the uterus of the baby coming into the vaginal canal?
You can. So you can have fibroids that kind of are like lower down on the lower uterine segment and can cause inadequacy of the pelvis. But I would say most fibroids are usually more fundal because the fibroid is soft tissue. And so only if it would have to be, I think, quite large to block
down there.
Yeah.
It's so interesting. I remember when I was a kid growing up, and let's say, I was born in the 70s. So by the time I was listening to conversations around me, let's say it was like the early 80s, and I was listening to women talk and my mom's friends and stuff, there were very few people who couldn't have children or couldn't get pregnant. I remember there would be one every once in a while that was like, it was sort of hush hush and it was a secret and it was very painful. And either the person, had a surrogate or the person adopted, but it wasn't something that was, one, very common, and two, and also it wasn't talked about. So who knows how common it was.
Right.
Honestly, because it's got so much stigma.
Yeah.
And also it was hidden. And so now that we're hearing more about it, it feels like it's so much more. But I wonder if it was actually always there.
I think that as experts, we think that it's probably a little bit of both. I think that we weren't talking about it as much as we are now. I mean, we've come so far in talking about it and destigmatizing it and creating support spaces for people to feel comfortable admitting that they're going through something hard. And I think also the rates have gone up for a multitude of reasons. The CDC, I think just last year, maybe 2 years ago, said the rate of infertility is now like 1 in 5 women, which is higher than we used to quote about 1 in 8.
Yeah.
And so it's probably a combination of women pushing off childbearing to later years. That's a huge factor. And another factor, which I truly believe is environmental toxins. I think that we're consuming more endocrine disruptors and synthetic material, and not just serving us badly in infertility, but also other hormonal abnormalities, thyroid, ADHD, cancers. I think we're seeing, and the rates of these diseases don't necessarily correlate perfectly with, risk factors like obesity. And so environmentalists and geneticists are believe that it has to do with environmental toxins. And I think we don't talk about it enough, or we don't validate it as true science enough. But the data's starting to come out, and I think we have to pay attention. Some common endocrine disruptors include plastics,
pesticides, right? Glycophosphates and things like that.
Pesticides, canned goods. There's so many. Fragrances is a big one. Synthetic fragrances.
Isn't that ironic? Because we use fragrances as a way to like attract and to be, feminine, if that's the way you roll. But it's to think of them actually causing harm. It's interesting because in typical fashion, a lot of times we blame the woman, right?
Yeah.
It's later, it's getting late. You should have had kids in your whatever age you were.
Yeah.
You chose your career before having children. That's one that I hear. And it's actually so many other factors that are contributing to this, and this multi-layered journey of infertility is not just one thing. And I can imagine that as a reproductive endocrinologist, it's like a moving target. You're trying, it's like Tetris. You're trying to look at the whole clinical picture and see which parts are humanly changeable, and then which parts have like this unknown of like the magic of conception, which the fact that it ever happens is something.
Yeah. I tell my patients in all their new patient consults that reproduction in the best case scenario is still highly inefficient. We have all our messaging to women is birth control, birth control, birth control, don't have an unintended pregnancy. But the true rate of pregnancy in a college age super fertile couple is about 30% a month at best. So reproduction is inefficient. To your point of, a Tetris game, I do think it's incredibly complex, and there are so many different layers. However, there's so much we still don't know, and so much that the evidence is so gray. Ultimately, what's amazing is that the technology that we do have, intrauterine insemination, but really IVF, for a host of unknown diagnoses or unexplained, which can account for 15 to 20% of women, they still have a good prognosis with IVF. And so that's the amazing thing.
I heard a statistic that in women the peak of fertility is at the age of 21. Is that true?
We think the young 20s. Yeah, we actually see, it's interesting. But when you look at these curves, these data curves on studies that have looked at aneuploidy, for example, or the abnormal amount of chromosomes, it actually is higher in the teens, and then gets lower in the 20s, and then rises again. So it is kind of interesting, because you would think the younger you are. I don't know if we have a great explanation teleologically for that just yet. But it is interesting.
Well, and we know that young teens have a hard time with labor and delivery.
Right.
The labor and delivery is actually more high risk.
Right. We say the extremes of age are risks for
exactly.
preeclampsia. Yeah.
For either one. It's so interesting. So I know that there's so much from the psychosocial perspective. There's a lot of fear in young women right now who are getting married and are like, well, should I just have a baby because I'm afraid I won't be able to have a baby later on? And what are your words of wisdom to someone who's maybe not even newly married, but newly in a relationship and wanting to be a parent one day? Should they just have one to make sure that it works? Or what?
I mean, it's never a good idea to just have a kid, right?
For sure. But I have heard that. I've heard that theory of have one
The
so
fear
that
is
you know that
real.
that it works, and then the other
fear
ones
is
will
real.
come.
I don't think that I would necessarily get on board with that advice because we see a lot of secondary infertility. So even though you've had one, you still have problems later.
Yeah.
But I do think that while I don't want to cause unnecessary anxiety and fear, I think that women need to know that the biological clock is very real. And there is no substitute for age, unfortunately. Even with IVF, we see decreasing outcomes as women get older in both quantity and quality. So their bang for their buck with IVF is lower. What I wish more women knew was to check in with their fertility doctors or even their OBGYNs and just see what their ovarian reserve looks like and think more about freezing their eggs, or if they're in a new relationship and this is their forever partner, but they're not ready to have kids, freezing embryos. Like, this is technology that's now available to us, and it is life-changing for so many people. I mean, so many people. And I just wish that it was out there more, that women should be proactively looking into their fertility, freezing their eggs. It's interesting because the American College of Obstetrics and Gynecologists, as a resident, I was kind of trained to not be overly looking at people's AMHs unless they asked for it, unless there was a reason for it. And we don't in medicine like to overly test, right? Because sometimes we find something that we then don't know what the significance is of. But my argument is, this is the 21st century. We all have anxiety anyways. Yeah. You're either going to have anxiety because maybe you froze your eggs and you didn't have to, or you're going to have anxiety because you didn't freeze your eggs and you should have. Right. And I would rather see more of the prior. I think there's very little, from my perspective, harm in checking in earlier and being more proactive earlier.
So what would that look like? What would the testing be, and who would it be with? And at what age do you recommend it?
Yeah, I would love to see the age shift from like mid 30s to younger 30s or late 20s even as a check-in for checking your AMH, which is a marker of ovarian reserve, maybe getting like an ultrasound every once in a while to see, are there fibroids that I should take care of now or try to prevent the growth of now, as opposed to playing catch up in a few years from now when I'm desperate to have a kid. Mm-hmm. And then checking in, like if it's low, maybe checking in a little bit more frequently. If it's not low, I think we have to also at the same time as encourage people to check in, do our share of counseling. The caveat is that just because your AMH is perfect now, it doesn't mean it's going to be perfect forever. And so if you disappear and I don't know, I can't give you a guarantee. And we have to really be, I've had so many patients come and tell me, oh, I checked with my doctor a few years ago and he told me I had the ovaries of a teenager.
Right.
You know? Right, and I'm like, yeah, but unfortunately the biological clock doesn't spare anyone.
Correct. And what have you been exposed to since I last saw you?
Exactly.
Also, that's the thing with testing, is it's one moment in time.
Correct.
It's not a forever thing.
It is, but I think that we can, like for the women that have like a low reserve already when they're younger, we can encourage them to freeze their eggs sooner. And I think that if we're checking regularly, hopefully we can catch women at a certain cost benefit point for them. Mm-hmm. And maybe that's my bias as a fertility doctor, you know, but from our perspective, we hate to see women when it's so late in the game and there's less options for them.
So the process of freezing one's eggs, from my understanding, is people take hormones to increase the ovulation, or how many are ovulated at one time, because the number of eggs is finite.
So you are born with the most amount of eggs you'll ever have. Women are born with about 1 to 2 million eggs, and by the time they're menopause, we're in the thousands. So you're really losing eggs kind of consistently all the time, and not just one egg a month like everyone thinks.
Right. How do they get lost?
They get resorbed by the body. So every month, essentially, groups of eggs are moving to the forefront of the ovary from this bank that you have.
Line.
Yes. Yeah. And they become, they have different sizes and we call them different things. And so your antral follicles are the follicles that we can see that are about 2 to 10 millimeters on ultrasound. And those are the follicles that we're capable of stimulating when you come in for IVF. Mm-hmm. And so what we do is we give you literally steroids, which are your own body's gonadotropins like FSH, LH, the hormones that help you recruit eggs, but we give it to you in high doses. And we try to recruit, instead of just one egg that month like you would do on your own, we try to recruit that whole group that was coming to the front of the ovary.
Wow.
And so essentially what we're trying to do is increase efficiency to find that normal egg through IVF.
Got it. And so when a person has egg retrieval, that is a surgery, the person is put to sleep?
Yeah, so the way IVF works is we give you these steroids for, 10 to 14 days. And during that time period, we do frequent monitoring of blood and transvaginal ultrasound to watch the growth of the follicles. And we're hoping a whole group of them are growing well. When the majority of that group looks like it's the right size and therefore the egg in size has reached maturity, then we trigger them and essentially cause them to ovulate. And before those eggs disappear from and get, released from the follicles, we do our egg retrieval. So it's timed very exactly with their trigger injection. And they are, at least at our center, under anesthesia. So they are unconscious. They will not remember it. They won't feel anything. And we go in there with a transvaginal probe attached to a needle and essentially poke right into the follicle from the vagina and aspirate all the fluid. And with it comes their microscopic eggs. So it's pretty
incredible.
neat. Yeah. And then we give those to our embryologists, who are our right-hand man. They do all the hard work and we take all the credit. They find the eggs, and if we're just doing an egg freeze, that's where we end. If we're doing embryos, we fertilize the eggs and grow them to embryos.
So there are companies who freeze the eggs. That's like their specialty, or do you do that in-house?
We do both. We do
Okay.
eggs and embryos in-house, and we freeze them and we actually hold them in our lab as well. Some centers will outsource them and send them to a holding facility.
And how long can they be frozen for?
So to our knowledge, they can be frozen for like the rest of women's reproductive lifespan. We have women coming back to thaw eggs that are 15 years old. But the upper limit of that is still kind of being investigated because egg freezing is newer than IVF. So when we freeze, eggs are just one cell.
Yeah.
So when eggs get frozen, and we now have advanced methods of freezing called vitrification, which we flash freeze the eggs, even because they're one cell and they're majority water content, sometimes they can have like icicle formation essentially, and they don't thaw as well as embryos, which are multicellular and therefore sturdier. So whereas embryos have a 98% thaw rate, eggs have about an 80 to 85% thaw rate. And so we're still learning what the upper limit is of freezing eggs, but we think that they're freezing quite well. We're seeing women thawing eggs and having babies from them years later. There are conflicting studies out there. I have seen studies that say that with the longer that they've been frozen, they're seeing less thaw rates. And then I've seen actually just a recent study that was saying no difference in thaw rates. So jury's still out, but I wouldn't let that discourage anyone. I would say it's your best shot, your best backup plan.
I just, the chef in me is thinking about when I put out chicken to thaw on the counter in the refrigerator. How do you thaw?
It's so funny because you would think that that's like specific to your brain, but I've had so many patients say this to me. Yeah. They're like, is it like fish that has been thawed? I'm like, no, they have the embryologists have a method for thawing.
It's like reverse. You have to like reverse it.
They warm it in stages, and it takes about an hour to thaw an embryo, or from the time they thawed it till we're ready to transfer it. It's quite cool. Yeah.
Is it true? I feel my grandma. There's a picture of my grandma in the corner of the room because she's with me all the time. Grandma's always with me because grandma was who told me to become a midwife. Aww. And she had all sorts of ideas about womanhood and motherhood and femininity and do this and don't do that and do this and don't do the other. And many of the things that I laughed at as a young mom or a young woman when she said, I'd be like, that's an old wives' tale. We don't do that anymore. Yeah. Including when she told me to become a midwife. I told her there's no such thing anymore because I didn't know there was still midwives. And here I am.
Grandma knew best.
Right, exactly. Or she told me that after a woman has had her first child, the second child, the pain of involution, when the uterus goes back after a baby, the cramps are more with your subsequent children. And I was like, how can that be? It's the same uterus. Why would it be worse? And sure enough, it's absolutely true. We know that women have more postpartum cramping after subsequent children, right, as a mother of four. So one thing she said was, the longer you use contraception, the harder it is to get pregnant when you come off. Is that true?
No. So we have tons of data on this. We do know that contraception, depending what type, but like let's say a combined hormonal contraception, one that uses estrogen and progesterone, can suppress the ovary. That is true. But it does not cause permanent damage to the ovary. We see return to fertility quite quickly after coming off of birth control, whether that is the combined pill or something like the Mirena IUD or the NuvaRing. There is one method of birth control that takes a while to leave the body, and that's the Depo-Provera injection. And for that reason, I don't like it because it does take a longer to return to fertility. But I mean, I see it in my practice all the time. We have women who want to freeze their eggs or freeze embryos and they're on birth control. And I'll always take them off for somewhere between, 1 to 3 months to see the ovary kind of wake up again and have a better response. So in the short term, potentially there's some suppression and it lifts quickly. We don't see long-term decline in fertility. I think that part of the problem is that birth control pills can mask underlying infertility or underlying hormonal symptoms.
Right.
So for example, if you have PCOS and you have irregular cycles and you're put on birth control pills when you're young because somebody wants to regulate your cycles or get rid of the acne or the hair growth, and then you don't come off of it for 10 years, let's say. So now you're in your mid-20s, young 30s, you come off of it and all of a sudden you're not getting a period. And they're like, oh, it's my birth control. My birth control messed me up. And it's like, no, that's just your baseline PCOS manifesting again. Or in the opposite respect, you started to have a decline in your quantity of eggs and you became maybe something that we call diminished ovarian reserve. And people may blame it on the birth control, but it was underlying. So the birth control comes off and now we see what we call the period a fifth vital sign. It's giving us information about your body and your hormonal cycle.
Can you talk a little bit about what PCOS is and the difference between a uterine cyst and an ovarian cyst when it comes to fertility?
Yeah. So PCOS stands for polycystic ovary syndrome, but it is a misnomer. It does not actually mean that you have cysts on your ovaries.
Oh.
Yeah.
Okay.
So it's a complex endocrine disease, and actually many women are affected by it. 15% of women by some accounts. Yeah.
Wow. Is it more within certain races?
I think we do see it ethnically in certain groups. Persians.
Yeah.
I once for fun made a post on this, but there's a lot of studies on PCOS that come out of Iran. And that was really curious to me. And I think it's because maybe we have higher rates of PCOS, more hair growth for sure. And I think that sometimes makes it confusing because sometimes it's just your ethnic hair growth, that's your baseline. And we think it's PCOS, but we definitely need more studies on racial disparities. Sure. Yeah. But, so PCOS, polycystic ovary syndrome, essentially the underlying hallmark of PCOS is that you have more male hormone in your body compared to other women your age. And that causes disruptions in your ovulation pattern, insulin resistance, and then it causes some of the symptoms like acne and hair growth that we were talking about before. In America, we use the Rotterdam criteria to diagnose PCOS, and the Rotterdam criteria puts a little bit less emphasis on the male hormone needing to be a criteria. So with the Rotterdam criteria to meet the diagnosis of PCOS, you need 2 out of 3. You need to have irregular periods, evidence of elevated male hormone in your body, and that can either be clinical signs like acne or hirsutism, hair growth, or biochemical like testosterone in your blood work. And third, evidence of PCO on your ultrasound. And actually recently they added that a very high AMH can also count for criteria number 3. So in theory, you could have criteria number 1, irregular periods, and criteria number 3, PCO appearing ovaries, but none of the male hormones. Mm-hmm. So there's actually been a lot of studies where they talk about 4 different phenotypes of PCOS, where not everyone with PCOS is going to be that classic picture that we think of like somebody with a lot of hair growth and acne and overweight, but actually you can have a lean PCOS subtype and they're still suffering from a lot of the metabolic repercussions of PCOS. And I think that we have underrated the insulin resistance, the role it plays in PCOS and the role it plays at the level of the ovaries. And so when we see somebody with elevated male hormone and LH levels, because LH is very similar in chemical structure, we check their hemoglobin A1C, and we actually can see improvements in their cycle, their fertility, their development of a follicle with insulin sensitizers.
So the GLP drugs can actually help fertility?
Absolutely.
Interesting, because they're battling the insulin resistance portion of the picture.
Correct. So not everyone who has PCOS needs to be on a GLP-1,
right?
But I would argue that GLP-1s are doing great things for especially women with PCOS. There is, just as a disclaimer, a black box warning on the drug that you should not try to get pregnant within 2 months of taking it. So we still think it may have teratogenic effects, or we haven't studied it yet, but for overall improving someone's health before trying to conceive, it can go a long way.
That's so interesting. So a person doesn't necessarily have to be heavy or overweight in order for a GLP drug to help them, or GLP-1 drug to help them with fertility?
Okay, so you're starting to get into like a little bit of the gray area.
Yeah, as I do.
You may know that there's like longevity studies that are talking
Yes.
about like microdosing GLP-1s,
For
even
sure.
in people who are not overweight.
Yes,
So
and
I think
Alzheimer's benefits and cardiac benefits and
yes,
things.
absolutely. And it's very exciting.
Yeah.
But for purposes of fertility, I don't typically put my thin patients on something like a GLP-1 unless I'm seeing evidence of very high insulin resistance. Usually what I do if I see somebody with insulin resistance who's thin is I start with inositol as a supplement. And I've seen like patients who come back for second or third cycles, you can see a clear improvement. So I'm a believer.
It's so interesting that insulin and blood sugar rules so much of the physiological systems of our body.
Yeah.
I think more than we ever thought it did.
Absolutely. There's receptors on the ovary.
If someone were to ask you, what is the number one reason you're seeing people have difficulty get pregnant? What would it
I think
be?
the number one reason is delaying of childbearing.
And how much of the infertility is being caused by the man's side, which we don't give enough credence to either? Is there a low sperm count? Is there sperm that is just not viable? Are you finding that to be, what percentage of cases is that the case, where the woman comes in and is like, hey, and then you're like, wait, you're actually clinically okay?
Male factor infertility is very common. It is 30% of the time the reason for infertility and 50% of the time a contributing factor.
Wow.
Yeah. So I think we do
That's
need
high.
to, yeah, it's high. We need to spend, we do need to pay more attention to male fertility. And interestingly, in some ways, sperm is a little bit easier to improve than eggs, right? Like we're born with all our eggs. There's really not much we can do about it. Sperm is consistently being generated. Every 3 months, sperm becomes mature, capable of fertilizing an egg. And so toxins that males consume, and something we don't talk about enough is alcohol. Like alcohol is a very big toxin, and very accepted, tolerated, and in large amounts, and that's not great for sperm. This doesn't make me very popular, but marijuana, we have great studies showing not good for sperm or eggs. And then there's more obvious ones, which I see less and less, like nicotine, cigarette. And then just anything that increases heat to the testicular sac we think is bad for sperm too. We actually hope that when we remove certain lifestyle factors or risks from men, that we'll start to see improvement in their sperm a few months later. There are supplements for men just the same way there are supplements for women. And yeah, I would encourage everyone to not forget that that's a huge part of the equation.
So as a reproductive endocrinologist, do you also look at the male side, or are you focused mostly on the woman?
So a standard part of our evaluation is a semen analysis, and I like to add on something called a DNA fragmentation test, which is a little bit newer and a little bit more controversial as to its utility. But essentially, it's a very basic look at the sperm. And if we see something there, I will send them to my colleagues in male reproductive urology for a more detailed exam and history to see if there's anything that can be modified or surgically corrected or what have you.
How do you think that we could help women in our society have babies sooner? If we're looking at age as such a big component, and we know that there are so many factors that go into the decision to have a baby, whether it's the amount of help that you have. I mean, I as a midwife work on the other side, and the number of people who I see who are pregnant, having kids, and have absolutely no support, or have to go back to work immediately, or are working 3 jobs just to make it happen.
Yeah.
What do you think, if we could wave our wand, if we could wave our societal magic wand, what would you like to see?
Pre-conception, I would love to see more companies ensuring, and hopefully we are moving in that direction, ensuring fertility treatments and fertility preservation.
Amen.
And also fertility diagnosis, which we've come a long way, but there's still a ways to go. And then through pregnancy and post-birth, I mean, there's no question that we're one of the worst countries in terms of maternal fetal support, time off, resources. I mean, in Israel, it's like mandatory to see a pelvic therapist after after you've given birth.
Yeah.
Here, it's like only if you complain, and
Right.
and then you have to find a good one, and is it covered, and all that stuff.
In Amsterdam, where you could, I think 40 to 50% of people still have babies at home.
Mm-hmm.
And the midwife who actually catches your baby and does your care
Yeah.
has privileges at the hospital. So if you need to transfer, the same midwife takes you in,
Amazing.
which here is hard to find. I mean, we have a
Amazing.
couple, but then that midwife can actually come back and give you postpartum support for a certain number of weeks
Right.
into your postpartum period.
Yeah.
It's mind-blowing and so
I mean, in the
commonsensical.
Persian culture, I mean, my mom would say that for the first 30 days after you give
40.
birth, 40 days,
40 days.
you're not supposed to leave women
Yep.
alone, right?
Exactly.
We're the
Correct.
only ones that are like, all right, get back to work on Monday.
Yeah. See you soon. Congrats.
Yeah.
See you in 6 weeks.
Yeah.
See
Okay,
you
cool.
for your 6-week visit.
Congrats.
Yeah.
We
Yeah.
definitely need a lot more support, and I would love to see that changing. And in the meantime, I think, raising awareness is so paramount, because some of the support that women need is mental health.
Yes.
And, that needs to be hugely destigmatized, and women need to be encouraged to quickly see a therapist or get on the meds they need. And they shouldn't be afraid of taking meds if they need to. And I tell a lot of my patients, this can be temporary. It doesn't have to be forever. It's
Right.
just to make sure that you're safe and your baby's safe and everyone's functioning. As a society, we're dealing with so much more on a daily basis than our parents' generation. And so I think a lot of times we compare ourselves. Why can't I do this and also be capable of doing this? But I mean, just today, how much news have we been inundated with, right? And we need to hold all of that in here and also do our jobs and also take care of our kids. So we need to hold more grace.
Absolutely. Tell me about the person whose labs, anatomy, physiology look perfect and they are still not getting pregnant.
So we call that unexplained infertility when, because what I tell my patients is, even though fertility is so complex and we've come so far, there's still so much we don't know. So it's not necessarily unexplained infertility as much as it's we don't know the reason for. And sometimes it's you're on the wrong side of statistics, and it's just kind of like statistical chance, or if you believe in a higher power, because like I said, 30% of women get pregnant each month in their prime fertile years, right? And then
that's mind-boggling. I thought it was like 80.
No, 85% in a whole year of trying.
That's crazy.
Yeah. So 15 to 20% of the time we don't find a reason for their infertility. And by the way, even sometimes when we find a reason, I wonder if that's truly the reason. Yeah. Like I said, it's not that there is no reason. It's that we probably don't have that reason in science yet to test for it. But IVF still helps these patients if they're not getting pregnant through lesser technologies like, ovulation induction, IUI. Yeah. So there's still a lot of hope for women who are not getting pregnant and can't find a reason. Actually, sometimes we say that they are the better prognosis patients, and that's probably because they were just on the wrong side of statistics and there isn't something truly wrong with them. But in the meantime, it can feel so isolating and so hopeless.
Absolutely. And that brings me to, within your practice, do you have a therapist or a psychologist who is also providing the psychosocial support throughout all of this? Because the journey is really not for the faint of heart. It can be the highest highs and the lowest lows.
Absolutely. It's a roller coaster. And I also tell my patients that we love to make fertile women feel like they're infertile. We're just looking so closely and we're finding all these things and we get anxious about them, you know, and a lot of times women will end up being just fine. And that's the good part of my field is usually we get to a happy ending. It's a very good prognosis field. But yes, we work very closely with multiple therapists and psychiatrists, coaches, support groups. There are multiple organizations out there that are providing support, group therapy, hooking you up with somebody who's been through something similar, whether that's male factor or donor eggs or gestational carrier, what have you. And we really try to identify the patients that we think need support and get them the support they need, because it makes a huge difference. Huge difference.
As we're getting to the end of our interview, I could talk to you all day about this. It's such an honor having you here, and so many questions are going around in my head. Are there things in nature that our clients or friends or people who, men or women, can partake in? I mean, we know that drugs and alcohol and certain environmental effects are going to be detrimental to fertility. But what can we do other than releasing stress and eating well and hydrating and avoiding pesticides and things like that? Is there a certain herb or a certain supplement that a man or a woman can take to help promote fertility?
Yeah, I mean, I think that we're discovering new things all the time. There's a lot of current supplements that actually do have some good evidence behind them. We're always exploring ones, ruling one out. I think if you were to ask an acupuncturist, by the way, they would probably say absolutely. And I can't speak to that because that's not my area of expertise. Recently, a lot of data has come out that CoQ10, ubiquinol, is very helpful. It's an antioxidant, and maybe it preserves the metabolic life of an egg a little bit longer and maintains quality for a little bit longer. We know that vitamin D can be paramount to fertility. I think it becomes hard because as somebody of Western medicine, we like really robust evidence to go suggesting things to people. Yeah. And we know that a lot of things, we're very risk averse. Yes. And there have been so many things that have come out and then we find a risk to it.
Yeah,
and
it's a practice of medicine, right?
Yeah, absolutely. So I tend to be a minimalist. Mm-hmm. And I also think that by giving women like 100 supplements to take, A, we're sending the wrong message. There's something wrong with you. There's a deficiency in you. You need to be taking all these things. And B, we're stressing her out. And we're adding so many variables to the equation that like it's not a systematic approach to figuring out or tailoring or moving in any sort of direction. We're kind of all over the place. So I tend to be a minimalist and really only recommend a minimum of prenatal vitamins, vitamin D and CoQ10 to majority of my patients. My PCOS patients, I recommend a few other things, or patients with a really diminished ovarian reserve. Mm-hmm. We'll try some more experimental things. And then I have patients that come to me with a list of supplements. They want to know if they can take them. And I say the same thing. Like I will point out to you the ones that I know obviously have had bad stories about them or may interact with your other hormones, but ultimately I don't really know. We still have a long ways to go on that. And I prefer that my patients are more minimalist also, because just because they're an herb, it doesn't always mean they're benign. And we know that they can have drug to drug interactions. So.
Absolutely. Lastly, how do you stay off the emotional roller coaster with your clients?
Who said I stay off the emotional roller coaster?
Can you, do you? I mean, in women's health, I mean, and I think as all care providers, there's a level of compassion that takes us to the work. And then we come home to our families and, they say, leave your work at your office. And it's like, really? You try leaving that at the office.
They say we expect women to work like they have no kids at home, and we expect women to mother like they have no job.
No work, yeah.
I am not a good person to ask about how I stay off the emotional roller coaster. I am on it with my patients. You can ask my nurses. It makes or breaks my day if we get a positive pregnancy or a negative pregnancy. For patients that are having, suboptimal outcomes, I do lose sleep over them. Mm-hmm. And I take comfort in the fact that the majority of my patients will move on, the vast majority, and graduate from me eventually, even though this moment in time may really suck. And
then they come to me.
Yeah, and hopefully come to you. And I also think that this may be specific to women. We really like to beat on ourselves. Like we love self-torture. So we love to review the case that isn't going as well as it should again and again and again in our heads. And we ignore the positive pregnancy test or the good outcome. We don't celebrate the wins enough. And I've spoken about this on my social as well. I think we really need to celebrate our wins more and keep our view of statistics and what's happening more accurate, as opposed to letting the negative thoughts overwhelm us. But it's really just because we care so much. It's really hard to leave it at work and not let it take over when you're home and doing other things. I struggle with that. But
not internalize it. Yeah. Yeah. Thank you for being my guest.
Thank you.
What an amazing...
We really got into it.
Oh, we really did. And honestly, I feel like we could have 2 or 3 episodes of just, the many layers. Next time you're on, I'm already inviting you on again. If you would like to be a guest, I would love to talk about some of the things that we're seeing in pregnancy and delivery of people who have had fertility.
Yeah, there's a lot there.
There is some there. So coming soon.
I think we spoke about that maybe
on
the
phone. We spoke about that on the phone, and we're running out of time, but perhaps you would come back and grace me with being my guest. Yeah. I loved having you on.
It was great. It was very fun.
There's going to be show notes. I'm going to put information for Dr. Sahar Wertheimer on the podcast show notes, and you can reach out to her. And she's just lovely. Just lovely. Thanks
for having me.
Mamatoosa is hosted by me, Atoosa Benji, and produced and edited by Josh Stretton Carlson. Our theme music is composed by Mehri Lalazarian. If you'd like to support the show, please follow and review us on Spotify and Apple, or subscribe and like us on YouTube. This show is for informational purposes only and is not intended to be medical advice. Always consult with your healthcare provider when making medical decisions. See you next Tuesday.